I think in general, the main thing is that people should be proactive with their preventative health, and that probably the number one thing that people should be doing that would promote longevity and decrease their risk would be physical activity and exercise.
Yay Networks.
A quick note before we dive into today's podcast. If you like what you hear, I would love for you to subscribe to Fueled Wellness and Nutrition, wherever you download your podcast. It would also be incredible if you take a minute to rate and review this podcast. Those things do matter, and they really help us. If you've listened to this podcast before, you know that I am very much a realist, very much not a person who employs, fear, scare tactics to bring about a behavior change. I do want to share with y'all, though, a story that our family and my dad experienced that really taught me, and it really highlighted the importance of listening to our bodies, paying attention to warning signs, reaching out for help when we think we need it, not being afraid of being a hassle or a nuisance. And really, in my dad's case, it had a really beautiful result, a very positive outcome. And as I've reflected on this, there's just really so much that we can take away from learning from this about when to be specifically proactive when it comes to our own health and the health of those we love. We're back this week with Dr. Chip Lavie. You heard him several months back. We talked about omega-3s and fish oils and what the science says. And I asked Dr. Lavie to join us again this week. I really wanted to talk through an event that was pretty impactful to me personally. And it's something that I found myself sharing with people along the way, just kind of by the ways in the conversations. And I wanted to share it with y'all on this podcast and also bring in Dr. Lavie, the cardiologist, as the expert and kind of helping explain and help me share the story with y'all. And then also when to be concerned, when to be alarmed. So before we get into the story, Dr. Lavie, if you can introduce yourself again for anyone who hasn't heard our fish oil podcast yet, and then also, kind of a little bit about you to explain why I brought you in.
Thanks, Molly. I'm a clinical cardiologist at Ochsner. I'm medical director of cardiac rehabilitation and preventive cardiology, but I spend a large amount of my time doing stress testing, running the cardiac rehab program, but just really seeing patients in the office, either to prevent heart disease or to treat heart disease, and some people that have had heart attacks and stents and bypass surgery to try to prevent their disease from progressing. So those are all the things that I'm very interested in clinically.
And from a patient perspective, you're incredibly passionate and people use the word like bedside manner, but the way you relate to and connect with your patients is admirable. The way you dive into the science also, you have a real special talent, I think, for both.
Well, appreciate the kind words, Molly, but it really is something that many of us do in cardiology because there is a lot of science involved in what we deal with, but sometimes you can be an expert at science and the problem is you have to translate that to the bedside, to the patient. And sometimes it's probably even more important to have better relations with the patient than it is to have all the detailed minutia that you can get to with the science. Certainly, I think, most of the good cardiologists are going to know the general science. I think knowing some of the minute details, it would be probably way better to be good at bedside diagnosis and treatment than necessarily being an expert scientifically.
And that's sort of what we're talking about today, because the story that I'll be sharing is related to my dad and the experience that he and our family has gone through. And he's 82, and he lives in Baton Rouge, and so his healthcare providers, his cardiologists, they're based in Baton Rouge, and exactly what you just said. When he's recounted what his cardiologist, how he has shared things with him, and of course he shared with me the notes and the chart notes and things that his cardiologist has written up. In it, even in the written word from his cardiologist, I can hear the compassion. As you read it, it's very empathetic in the way that he's communicating even the chart note, but then also how he communicates with my dad, which I appreciate. So to share with our listeners, basically my dad, 82, I've talked about him a lot on this podcast before. He and I are incredibly close. And so Dr. Lavie, he has been, really what you would look at as like a model of health, the vast majority of his life, since about his late 20s, 30s. He's been a runner. He was a runner until, just a couple of years ago when just physically he couldn't. But he started jogging, like back in the early 70s before people were jogging and before they really had running shoes. And it was like, your normal street shoes. And people are like, why is that guy like running down the street like that? So he was one of those. And then he's really the reason that I had such an interest in nutrition, because he was always very proactive, very health minded, again, in the 70s, early 80s, and did things before it was the norm. It was one of those things that it was just, to me, it was like a gut punch, because my whole life, like if you would have ever asked me, is your dad at a risk of having a massive heart attack? The answer would be no, like not anywhere close. I always had concerns that he had had non-Hodgkin's lymphoma when I was younger, and I always had concerns that cancer would come back or there would be some other thing. You have those worries, especially when you see the mortality in your parent. When I was in my early 20s, to see him go through cancer, it changes your viewpoint and you see your parents through a different lens. And my mom had a lot of health issues. You and I had talked about that as she was going through those, and she passed away. And so to see that mortality in your parents, you start to have a worry. And it's not in the front of your head all the time, but it is in the back of your mind. But a heart attack was just never even in the cards.
Yeah, and so and obviously, you kind of, with your dad's history, you kind of would have expected that he would be making it into his 90s and nothing
Right.
happened to his
Right.
heart, and but still, it's never a
Right.
shock when an 82-year-old has some heart issue.
It's still, though, it's just from our perspective, I think it felt just like a stunner. Um, I'll say though, kind of going through the story of what happened, what was interesting, and I think this is where, learning and I guess hearing this for our listeners and not dismissing something and not blowing things off. So he it was actually back in October, late October. He and my stepmom had actually had COVID. And it was, they'd had it for 10 days. They had a real mild case, each of them, thankfully. And it happened to be, I remember it was like a Thursday morning. I call him. It was probably like around 8. Hey, Dad, what's up? How are you feeling? And he's like, oh, with COVID, you mean? And I thought, of course, like, they hadn't been able to come to an event we had and all this stuff. And, COVID was like at the forefront of our minds. Well, his answer of that was because he was sitting in the emergency room. But you know how parents are, or grandparents, they don't tell you sometimes when stuff is actually like in the middle of happening. So he had in the middle, early hours of the night, 4 o'clock or so in the morning, he had woken up. He woke my stepmom Pat up, and he was feeling what he perceived to be chest pain in his left arm and in some chest pain. And, he knew a couple of things that I think were good. And also just for our listeners to be aware of, it felt different than what he had ever felt before. And so he knew also, just with his age, am I having a heart attack? And so he called, 911, knowing that, tell our listeners the difference of driving yourself to the emergency room versus taking an ambulance.
Yeah, so obviously, I mean, a lot of people, if they're not really worried about themselves, don't want to necessarily take an ambulance. The problem with driving yourself to the emergency room is, if you really are having a heart attack, you could lose consciousness on the drive, which is actually very dangerous to you and for other people on the road, and for anybody else in the automobile with you. And even if, for example, if your spouse is driving you to the emergency room, they can't do
Right.
much if they're driving and you pass out and
Right.
your heart stops. And so and the problem is that you could say, if everybody called the ambulance for
Right.
everything,
Right.
there'd be a lot of people with, muscular pain, or having just, esophageal
Right.
reflux, or having a spasm in their
Right.
ribs, and that has nothing to do with the heart, that would be taking ambulances. And so you could probably certainly overuse
Right.
ambulances. But the problem is, if you really were driving yourself or having, a friend or a spouse drive you in the middle of a heart attack,
Right.
that would not be smart either. And so it's sometimes a tough call.
Right.
But if you're thinking that it really could be heart, it probably would be best not to go by, with a, in an ambulance or a medical.
And talk to us about the difference of when you arrived there and the care and treatment.
Yeah. So first of all, I mean, so obviously, if you arrive in the emergency room in an ambulance, it's generally considered more serious than
Right.
somebody walking in the emergency room
I think that's
out of their
where
car. And
you hear these
so,
stories of people who do drive themselves and then they have to wait for hours versus if you
yeah,
truly are having an event. I think this is also one of the things that the Heart Association, the American Heart Association is has continually tried to get that message out also.
yeah. So I mean, obviously, if somebody walks in the emergency room saying that they're having bad chest pain, they are usually treated seriously. I mean, they usually, somebody who says they're having chest pain, it's very often it's
Okay.
heart attack into proven otherwise. If somebody walks in the emergency room and says I had some chest pain 2 hours ago, they might wait a while.
Right.
But if somebody's having active chest
Right.
pain, they usually are going to take that
Okay.
seriously. Realizing that the active chest pain could have been because they got punched in the ribs and they could have just
Right.
eaten a spicy
Right.
food that they haven't having reflux, or it could be having a gallbladder attack. And many chest pains is not hard,
Right.
but there's three really big serious causes of chest pain, and one is blockages in heart arteries, which is causing heart attack. A second is a pulmonary embolism, which is a blood clot that breaks off somewhere in the body and goes to the lung. And then a third is tear in your aorta, which is called aortic dissection. Those are all really serious causes of chest pain that need to be treated, very
Immediately.
urgently.
And so going back to kind of the message that the Heart Association gives, like about taking the ambulance, does that help to essentially like reduce or minimize any chance that you would be
Yeah, sure.
have to
So the,
wait?
the nice thing about the ambulance is that one, if you were having something really bad and you arrested in the ambulance, they can
Right.
resuscitate you right away. So you're going to get immediate medical attention. Where you're not going to get that in you if you drive in the automobile, you crash in the car. If your spouse is driving the
Right.
automobile, you're dead in the passenger
Right. Right.
seat, and they can't do much about it. Whereas in the ambulance, you're going to be resuscitated, and they're going to be working on you real quick. Second is that it does have a higher impact when the ambulance drives up with a patient. It's a little bit considered more serious than somebody walking in, themselves. And that's kind of that's not necessarily the case, because somebody could have some
Right.
minor illness that
Right.
taking the
Right.
ambulance, and somebody could be having the middle of a heart
Right.
attack walking in themselves. But still, the impact of visually seeing an
Yeah.
ambulance drive up is generally considered more
Yeah.
serious. So you're going to tend to get a little bit faster treatment. But like I said, for chest pain in the emergency room, the norm is to be treated
Right.
pretty quickly, regardless of how you show up.
So he shows up and they run different tests and they kept him there for several hours to look at, markers. Did he have a heart attack? Was he having a heart attack? Had he had a heart attack? And looking at everything to see why is he experiencing this pain? And they ran, blood tests, waited several hours, did more tests, different, EKGs, and they didn't see anything that showed that he had had a heart attack at that time. And so for our whole family, we were like, well, that's a relief. And none of us felt like, oh, well, that was kind of silly. Like, oh, that was a dramatic decision. For us, we thought he is experiencing a pain he hadn't had in his chest and his left arm. He was listening to the signs. He took all the correct steps. And if nothing else, it gave him a peace of mind. And again, being 82, he's going to be cautious on this.
The other thing that you said earlier, Molly, that should be kept in mind too, is that you said he was just recovering from COVID.
Right.
And COVID is known to do a number of things to the heart, because one, it increases blood clotting. And so the blood clots are what usually causes a heart attack. It's blood clotting on top of a plaque in the heart artery. Um, the COVID can actually attack the heart and cause a myo or pericarditis that can cause chest pain and actually cause damage to the heart. So COVID is significantly a risk factor. And it's been shown, and we have actually a paper that's submitted right now showing that patients who show up with a heart attack with COVID have a much higher mortality than people who show up with a heart attack that don't have COVID. And so COVID is actually a risk factor,
in itself.
itself. So so it sounds like, and I didn't actually see these records, but it sounds like that your dad showed up in the emergency room, had described chest pain. The doctors probably thought that that in an 82-year-old you
Right.
can't just
Dismiss it.
negate any chest pain, but they probably didn't think it sounded like classic heart pain. They thought it probably could have been something else other than the heart. And then his EKG probably didn't show
Right.
anything bad.
Right.
And they probably did a blood troponin test, which is a blood enzyme that used to diagnose heart attack. And they probably did that a couple of times,
Right.
and it probably was all negative. And so they at least that doesn't mean that his pain was not hard, but it probably means that he didn't have any dramatic heart presentation, and that he didn't have at least a heart attack. And so, I mean, evidently they
Right.
felt comfortable
Right.
enough, at least not keeping him in the hospital and letting him go home and to get follow up with his with some
Right.
physician.
So for us, we had that sense of relief, and like I mentioned, this was a Thursday. They said, just why don't you schedule with a cardiologist to get a stress test done? And so my dad is, um, I think a lot of us, it's easy to push things off. It's easy to postpone or procrastinate. And he's really proactive in all types of ways, and especially in his health. And so by Tuesday, he had the stress test scheduled. And so that was all on a
Which is very
Thursday.
fast. So that's just 4
Right.
days,
Yeah.
3 work days later, having a
Yeah.
stress test. And sometimes we really worried about stuff. We actually do the stress test before they leave the emergency
Mhm.
room even. But certainly if it doesn't seem that worrisome, we try to get a stress test for the next day or for the next
Mhm.
week, and that's usually pretty fast action. And your
E
dad got sounds like pretty fast action.
Exactly. And so none of us had, himself included, really had any expectations that there would be anything significant of that stress test. And so this is where I think it's just really important, again, to be proactive. And again, someone like you go into the ER, they run all the tests that you mentioned, and okay, you didn't have a heart attack, everything's fine. It would be really easy for someone to leave and go, you know what, everything's fine. I know I should do that stress test. I'll get to it. And then a couple of months later or whatever, or we just put things off and other things get in the way. So as he goes in for the stress test, we really, it was in my mind, and I checked in with my stepmom and, hey, how's it going? And when she sent us the message that he had 90% blockage in the LAD, which you said it is, I guess, explain that to us. It's what's referred to as the widowmaker.
Yeah, so there's 3 arteries in the heart, and the arteries are called the left anterior descending, which is abbreviated the LAD. The other one is the right coronary artery, and the other one is the circumflex artery. Um, and those are the 3 main heart arteries. But the most important of the 3 is the left anterior descending, which is abbreviated the LAD. And I I think you showed me the papers that the dad's, got a stress test first, and the stress test had some abnormalities on the EKG,
Yeah,
and he
thank
had
you.
and also had some rhythm abnormalities that were called ventricular tachycardia. He was having a bunch of skip beats all in a row, and because of that, they were very worried that he possibly had a significant blockage, and so they did the angiogram, and they found that he actually had relatively minor blockages in most of his arteries, but he had an 80 to 90% blockage that they described in the proximal, which means the beginning part of the left anterior descending. That's the artery that lay people use the term the widowmaker.
Which is a terrible name.
Yeah, that's it. And
It's
it
horrible.
could be for a woman, it would be the widower maker.
Right.
But it's an artery that if you see a lot of people, and obviously people drop dead from many things, but somebody who has occludes their proximal left anterior descending, they often they occlude the vessel, they get a chest pain, and they go into a bad rhythm disturbance that causes their heart to stop, and so they basically drop dead and generally are not resuscitated, don't make it to the emergency room, and so that's how it got termed the widow maker. And there's other blockages that are important in the heart too, but that's the one that you really get into big trouble with.
because
So
you just
that's where
don't have time.
it's also feeding about, depending on the individual, it's feeding somewhere between 40% to as much as 60-70% of the heart muscle. And so it's supplying a big area of the heart. So if that area closes off, you can get into big trouble. So um, that's something that you so if you found a 50% blockage somewhere in the arteries, you can it wasn't critical to find that. Many people are walking around with 50, 60, 70% blockages, but having an 80 to 90% blockage in that area of the artery is something that's could certainly be causing a big problem. It could have been causing bad symptoms, and it could cause sudden cardiac death. And
And
so getting that treated would be a very helpful thing.
tremendous. And so I mentioned that we weren't really worried about the stress test, and I jumped to the blockage. And so thank you for telling the progression better. So he goes in for the stress test, and what was interesting was they noted the irregularities, as you said, during the stress test, and said we want you to come back in 2 days for the angiogram and looking at doing placing the stent, if needed. But it was funny because that was, like I said, a Tuesday, and they said, we'd like you to come back on Thursday for this. And my dad said, well, I'm going fishing tomorrow, and they said, we don't want you going anywhere and doing anything. Just lay low, like, hang tight and just, don't do anything strenuous. And then come in here. And they had some concerns. And then it was when they did the angiogram that they saw.
Yeah, and I think honestly, I mean, many times when you bring somebody back for an angiogram, like they bring back your dad, you might find that they just have modest
Yeah.
blockages that you don't need to do anything about, or you might find they have no blockages at
Right.
all, and they were having the rhythm disturbance because of just some electrical irritability, and occasionally, you find really bad, even worse than which you could have been
Yeah.
a 99%
Right.
blockage. And if you knew it was going to be a 99% blockage, you wouldn't have even let them go home. You would have
Right.
wanted to do the
Right.
angiogram that day.
Right.
And so I think they didn't
Yes.
feel that sense of urgency because his stress test wasn't that bad and your dad's symptoms weren't that bad.
Right.
But it certainly was worth that. It got filed, and it turns out that. I mean, you could say, well, could they have even moved faster? But he went to the emergency room on a Thursday, got a stress test on a Tuesday, and then an angiogram on a
Right.
Thursday. So within a week, he had an emergency room visit, a stress, and an angiogram, and so that's actually pretty fast action for someone who wasn't in the middle of a heart attack, when he showed up the previous week.
Let's take a minute to share about Caraway Home, partner for this week's episode. Caraway Home's non-toxic kitchenware collections make cooking and baking a piece of cake. We love our cookware. It's our go-to for everything from seared salmon to creamy spinach to our Eat Fit candied cashews. The pans heat up quickly, they cook evenly, and they're incredibly easy to clean. With our exclusive discount, you can now save on the full suite of Caraway products, including their internet famous non-toxic cookware set. Also, Caraway's food storage, tea kettle, and mini cookware. Visit carawayhome.com/fueled to take advantage of this limited time offer for 10% off your next purchase. This is exclusive for our listeners, so visit carawayhome.com/fueled or use promo code FUELED at checkout. Caraway, non-toxic cookware made modern. So what are, like, as someone is listening, because I think, the last element, I think, of his kind of story was that it turns out the chest pain and the arm pain that he was having, he continued to have it even after he got the stent, even after the flow was corrected through those vessels. He still was having this pain, and they identified that more than likely it's coming from a disc or a nerve or something like that. But the beautiful thing was that pain that he was perceiving in his chest and left arm and thought it could be a sign of a heart attack got him to take all those steps that ended up catching something that could have been really, really bad.
And so it is probably a good thing that if somebody had an 80 to 90% blockage, it would be good because to know about it, because you'd treat it with, being on a baby aspirin. If you weren't on it, you'd treat it with being on omega-3. Your dad was probably on taking
Mhm.
fish oil already. You treat it with certain medications to protect the heart. you'd usually treat it on a statin unless their cholesterol was unbelievably good. Even if the cholesterol was good, they'd probably put them on a statin to get it even better. So you do things for that type of blockage, and for it being that tight, if they thought it was symptomatic. So if you just said if somebody had an 80% blockage in that vessel, but it was causing them no problem, would you have to put a stent in? And that would be very arguable.
Yeah.
I think many people would do a stress test and see if the
Yeah.
stress test was bad, and then they'd put a stent if
Right.
the stress wasn't bad. But your dad did have a stress test, and the
Right.
stress test was bad. And
And
so the question is, was the stress test bad because of the blocked
right.
artery? But I know that you showed me a stress test that he had after he continued to have some symptoms, and the stress test after was not nearly as bad.
Right.
And so he was probably having
Right.
abnormalities in his heart because of that blocked artery. Now, he might have, like you said, he may have actually showed up in the emergency room because of having non-heart pain.
Unrelated. Right.
And so there's a lot of people have pain that it's not all due to the heart. You can have chest pain from your neck, from a disc in your neck. You can have chest pain from disc in your thoracic vertebrae, from your chest ribs arthritis. You can have chest pain from a gallbladder attack, from acid reflux, from just musculoskeletal pain. There's a lot of things that can cause chest pain, and obviously some of them are not serious at all. Some of them, have some seriousness, and others are very serious. And I mentioned the three serious is a blocked heart artery, the pulmonary embolism, which is blood clots breaking off from usually veins in the pelvic area or the leg veins breaking off and going to the lungs, or tearing your aorta, and that's called an aortic dissection. Those are all very, very serious. Many of the other chest pains are not serious at all, but it's sometimes it's hard to know. The most typical pain from heart arteries is typically having a more burning, squeezing, a pressure in the chest that happens more with exertion and goes away with rest. The problem is that not all heart pain shows up like that, and there's a lot of less typical presentations than that. And so the problem is we have some people that they have symptoms that end up proving it was from their heart that honestly didn't sound that much like it was from the heart. If you didn't take it a step further, you would not have found the very significant heart block. It might be that your dad actually was having symptoms that may not have been from the heart. It may have been from his arthritis in his neck that was causing like a neuropathy pain, and that he got the heart artery blockage discovered because of the
Right.
heart tests that were being done, because the doctors were at least concerned that it might be heart pain.
Which is sort of our sense, that is sort of the progression of what happened.
And
It
I do think at least it does look like, even if his chest symptoms weren't all heart, he was having abnormalities on his stress test that were pretty serious abnormalities that kind of went away after they
Right.
put the stent in.
Right.
So it probably he was having legitimate heart problems, but his what brought him to the emergency room that day might have actually been non-cardiac, pain.
Right. So then our thought is, at what point do other people, like, he had normal blood pressure and he wasn't on medication for blood pressure. He wasn't on medication for cholesterol. Those were all normal. So if you were to look at him, and we talked about how healthy he's been and, doesn't have blood pressure or cholesterol issues, you would never think that. So then at what point or what age should people who are listening, or people who are listening and thinking about their parents, what warrants asking someone to talk with their doctor about getting a stress test, for example?
Yeah, so generally a stress test is done, but either having some worrisome symptoms, and you generally would not do stress tests if somebody's having no symptoms at all. Sometimes a stress test is done because somebody has, if you do something called a coronary calcium scan, that's a scan that the insurances right now don't actually pay for, but it's a pretty cheap test now. People at most places are charging somewhere between $75 and $125 for the test, but it's a test that tells you, do you have plaque in your heart arteries? And a perfect score is 0, and you can have scores in the many thousands. Your dad actually did
Yeah.
have that test that you showed me back in 2014, and his score was far from zero. It was in the 300s. But that would have been about an average score for at the time. He was a 74-year-old male, so he had about the average. Now, again, the average in the United States is not super good, and there would be a few people even at 74 that would have a perfect score of zero. But also, there's a lot of people at 74 that have scores in the thousands. So I don't think anybody would have been super worried about your dad's 300 score if he was not having any symptoms and he was not having high blood pressure or bad cholesterol. Now, if his score would have been 600 or 700, they probably would have at least put him on a baby aspirin and maybe treated his cholesterol even better, even if unless it was unbelievably good. So a lot of times people say my cholesterol is good, but it's not. It's having an LDL that's
Mhm.
not 50 or 70. It
Mhm.
might be having an LDL of 100, which would be way above,
Mhm.
way better than the average LDL. LDL is the bad, low density lipoprotein is considered the bad cholesterol. But but um, but if it was 100, which most people would consider very good, we might want to get it in somebody who has got a lot of heart plaque down into the 50, 70 range.
So the things to think about if someone's listening and they're thinking again about themselves or they're thinking about their parents or their grandparents, blood pressure, cholesterol, those are sort of like the easies.
Smoking, diabetes, and physical inactivity are and
Mhm.
obesity are the big risk factors for developing artery
And
disease.
if all of those were normal in someone, then also looking at calcium score. And like I said, if that's not covered by insurance, but it might be 75 to $100. And if someone had any one of those flagged as abnormal, would that justify what would justify? Because
So
here's where I think we are like
yeah, so
our
still,
in laws and
I
stuff are
think
like,
that the absolute need to do a stress test would be having symptoms.
okay,
Probably many people would do a stress test for somebody who has a very high calcium score.
okay,
Let's say the average score for a 74-year-old man would be 300. So, but let's say if you were in the top 10 percentile or top 25 percentile, having scores of 700 to 1,000, many people would do a stress test for
okay.
that. And then some people would do a stress test for multiple risk factors.
Mhm.
So if somebody had a combination of diabetes, smoking, high blood pressure, and
Mhm.
bad cholesterol,
Family
some
history.
family history that sometimes people would do a stress test for
Mhm.
that. It, that's not an absolute. So it would not be wrong to not do a stress test for multiple risk factors in an asymptomatic individual. I do think that if you had symptoms, you really should do it,
Mhm.
and then you probably should do it for very, very high calcium scores. If you do the calcium score, now the thing about the calcium score is there's no guideline that says you have to do that in
Yeah.
anybody.
Yeah.
It's not considered an automatic test. We do it, in many people, but a family practitioner is not wrong if they never
Right.
order a calcium test in anyone,
Right.
unless the patient asks for it.
And I think that's where again, using my dad as the example, when someone doesn't have these, you know, notable or outward risk factors, yet something could be underlying there. For him, it was doing the stress test that actually flagged, oh wow, there's something
Yeah,
to be concerned here for. But there wasn't any of those other things we talked about. The calcium score was modest, but it wasn't anything there either. So it was like, then our takeaway was, wow, what about, my in-laws, my husband's parents, and
yeah.
if someone is in their 70s and has AFib or,
Yeah,
what are
and then
the
so you can sit back and go, okay, would it be a bad idea for almost anyone in middle age and older ages to get a stress test? And the problem with that is that you do have to look at the cost of the stress test and what are you going to do with the results of the
Mhm.
stress test, and that's the problem with. And I just give you an example. If you go down to the girls' high school and do a stress test on all the 15-year-old girls who all have perfectly normal hearts, statistically,
Right.
but you do a stress test on 100 girls, 10 of them are going to have an abnormal stress test. So on those 10, if you did the stress test, what are you going to do? Are you going to send them to do an angiogram? or are you going to, plan on are
Right.
you putting them on strong medicines for their heart when they have nothing wrong with their heart? So the problem is you have to think before you do test,
Mhm.
what are you going to do with the results?
Mhm.
And so a stress test has got very low risk. I mean, so if somebody has really badly blocked arteries, they can drop dead from a stress test. That only happens a couple of times a year. It's very rare. And in fact, if somebody drops dead on or if you're going to have a bad event on a stress test, you're probably at least in a good setting for that to happen in the middle of a medical office rather than happening when you're out walking in the park or walking to your car or just walking up the stairs in your house. And usually it's because you have a badly blocked artery and something's going to happen soon anyway. Um, but so a stress test is pretty low risk. The issue there is a certain cost to it, and then what are you going to do with the
Mhm.
results? And so generally, that's why the recommendations are to do it for worrisome symptoms.
Mhm. Okay.
If somebody has got some risk factors. Now, again, if an 18-year-old is having chest pain, the chances are it's not their heart artery. The
Right. Right.
chances are it's something
One
else.
of
And
the other
so you
things,
could
right.
you don't have to do a
Right.
stress test in an 18-year-old girl who's having chest pain unless it really does sound like cardiac. And even if it does, it's probably not going to be cardiac, but you could do it. But the more when you start getting middle age and risk factors, if somebody's having symptoms um, that could be heart, then it's certainly worth doing a stress
Right.
test. And then that allows you to, if the stress test is bad, to act more vigorously. Um, and like I said, the problem is that I think most people would not recommend just taking every 80-year-old
Right.
and doing a stress
Okay.
test
For these reasons.
for
Yeah.
those reasons because you know a lot of 80-year-olds have some blockage in their heart artery. If they perfectly fine, they've never had a heart symptom, but statistically, there's going to be a lot of 80-year-olds that have some blockage. And just another example, if you take 82-year-olds who die from some other reason, if you do an autopsy on them, you'll find a lot of blockages in their vessels. But if they die from whatever they die from, if you do an autopsy on their prostates in the 80-year-old men, 30 to 50% will have evidence of prostate cancer. So do you need to look for prostate
Right.
cancer in all 80-year-olds when it's not doing them any
Right.
harm?
Right.
And then if you find it, what do you do about it? You could actually hurt them by trying to treat the prostate cancer aggressively. It's totally different. If you find prostate cancer in a 50-year-old, you definitely want to treat it vigorously. Find prostate cancer in an 85-year-old, maybe you shouldn't have looked for it in the first place. And that's the idea with should you look for blockages in people who are doing fine?
Right.
And the answer is, without your dad showing up with
Right.
chest pain in the
Yeah.
emergency room, I don't think anyone would have probably recommended doing a stress test prophylactically.
Mhm. So on this, the takeaway is really tuning into things. So blood pressure, cholesterol, diabetes, being overweight, being sedentary, smoking, those are all going to be risk factors and starting to be aware of if people, your family, your parents, your grandparents have these risk factors. Getting a calcium score can be another tool and starting to assess that, if you have one or more of these, then talking with your physician, am I at risk for this? Should we explore this further? And I think just at least bringing that up because how many people also aren't going to even their primary care on the
Yeah,
regular
correct. So
basis?
it can't hurt for a patient and their clinician to make a shared decision. Is it worth taking it a step
Right.
further? Certainly more important than a decision if they're having no symptoms, even with those risk factors. More important than the stress test is treating the diabetes, treating the sedentary lifestyle with
Right.
physical activity, uh, treating the cholesterol, treating the blood pressure. And if you do all of those things, you've done a tremendous amount to lower cardiac risk. And as we discussed a few weeks ago, being on omega-3 will lower your risk. Fish oil will lower your risk as well. And if you do have bad risk factors, and especially if you have a really bad calcium score, I think many of us would recommend at least being on a baby aspirin per day. Generally, right now, the recommendations for antiplatelet therapy, which include baby aspirin, is generally for people who've already got known heart disease, like a blocked
Right.
artery or a stent or a bypass surgery, or um, uh, if you have a lot of blockage in your heart arteries. I think right now the guidelines say as for just prevention over the age of 60, baby aspirin is not considered to be routinely recommended. I think many of us believe, though, if you knew somebody over 60 had a very high calcium score, like 1,000,
Right.
I think many of us would
Still
recommend a
do it.
baby aspirin.
Right. Right.
Where we wouldn't. So, for example, it would not have been wrong for your dad having a score just in the 300s at age 74 when he got his calcium score. It wouldn't have been wrong for him not to be recommended to be on a
Right.
baby aspirin. In fact, the guidelines right now actually say not to routinely give people over the age of 60 baby aspirin unless they've had, significant heart disease.
Right. Right. And then when we're looking at the medications, I had a question about this. Like what to expect? Like, so he is taking beta blocker, aspirin, Plavix.
So the reason he got a stent in his left angioedema descending, and so after a stent, you usually use what's called dual antiplatelet therapy, which includes aspirin and one of the stronger platelet drugs, which one would be clopidogrel, which is Plavix. Another one would be ticagrelor, which is Brilinta. Another one would be prasugrel, which would be Effiant. And generally, they combine the baby aspirin with one of those agents. I think your dad is on a beta blocker too because of the rhythm disturbance.
So let me
Uh,
ask this: when people do, kind of going back to what you were saying of
and
like,
on your dad's list right now, I do not see a statin, and
right,
most of the time people would be on a statin
right,
again unless your dad's cholesterol was just
right.
unbelievably good even before. If it was still very good, but it wasn't unbelievably good, I think many people would have him on a low dose statin. But maybe his cholesterol was so good that it was like too good to put him on a statin. But again, I don't know those values.
And with the medications, because that kind of goes back to kind of like you were saying, at what point, is a stress test needed or how are you going to treat it? One of the things that, and this is just something that if someone is going through these, has a heart event or on beta blockers, I've had clients just over the years tell me that when they're on a beta blocker specifically, that they felt low energy or almost depressed. Is that a normal?
So I think many, um, I mean, there are certainly side effects of beta blockers. We end up using a lot of beta blockers at even high doses in people who have damaged hearts,
Mhm.
people who have badly blocked heart arteries, people who have a bunch of rhythm disturbances. They end up being very effective to treat those. But beta blockers do block adrenaline
Yeah.
and they take your zip away. So
Yeah.
for example, if you just put a tiny amount of beta blocker in the marathon runner's water bottle, you could kill their race. So
Really?
they wouldn't run
Really?
nearly as good. So
Yeah.
say somebody who's running a 2 hour and 10 minute marathon, like winning the marathon, if you put a bunch of beta blocker in their water bottle, they'd run 20 minutes slower
Is this
because
just a hypothetical or has this
no,
ever been
no. I mean, I
studied?
think it's well
Wow.
known
Yeah.
that what beta blockers do is block the adrenaline, and so they slow your heart rate
Wow.
and
Yeah.
block the adrenaline that you need to do
Yeah.
better. And so people take beta blocker in small amounts before they give in big speeches.
Like a anti-anxiety.
Yeah, so people have stage fright will
Yeah.
take a beta blocker before a big lecture, or people who are actors may take a beta blocker before
Interesting.
going on
Yeah.
stage, or people who are pianists or violinists who go on
Yeah.
to perform, they might take a small dose of beta blocker to block that stage fright. Well, people could do that theoretically if they're shooting archery or
Right.
or or, or doing rifle competitions. They actually check for it in the urine because it's illegal to
Wow.
use because
Yeah.
it would give
Yeah.
you an unfair advantage.
Right. To have
Where
that like calmness and
whereas if you
steadiness.
if you were an athlete like trying to play basketball, or you were trying to run a race, or you just need the adrenaline to get through your daily activity. Like if
Right.
you're a vigorous
Yeah.
businessman, or you're doing some kind of high performance job, you might feel like the beta blocker takes your zip away,
Yeah.
and could hurt your performance. And so and sometimes we still forced to use it for people who really need it. But again, you might not try to use it in somebody who doesn't absolutely need to be on a beta block, or you try to use lower
Right.
doses that they can tolerate better.
Yeah, because they'll say, "I just don't feel like myself," or I feel, maybe they're perceiving it as feeling fatigued or like a little depressed or something's just not quite right. Like,
Yeah.
yeah. And it's probably like you said, taking your zip away is a good way to understand it. And those analogies I think are really good. What are other things like, so kind of just like an overall takeaway, like when you're at a party and someone learns that you're a cardiologist and they're like, if someone is, what are your kind of picture things that like you're guiding someone of when to worry, when to be concerned, when to be proactive, or when to blow something off or say this isn't a big deal?
Yeah, I think that there's such a spectrum. It's hard to simplify it that much, but I think that you generally would not want to blow off significant chest discomfort, particularly burning pressure, squeezing in the heart that in the chest area that was coming on with exertion and lessening with rest. You wouldn't want to blow off significant shortness of breath that's occurring with exertion, especially if it's new onset. You wouldn't want it to blow off your heart taking off and racing, and for no reason, and those are all things that you definitely would want to pursue because they can be from serious things. I think in general the main thing is that if people should be proactive with their preventative health, and that probably the number one thing that people should be doing that would promote longevity and decrease their risk would be physical activity and exercise. And I think that that's probably one of the biggest threats to health in the 21st century is just this tremendous amount of physical inactivity and sedentary lifestyle in our society. And then in addition, not smoking, getting your cholesterol treated if it's bad, getting your blood pressure treated if it's bad, getting diabetes treated, and of course, regular exercise would prevent diabetes in the first place, and regular exercise would prevent the massive weight gain that's occurring in our society as well. And so you put all of those things together, that you start adding these bad risk factors, it markedly increases your odds of developing heart disease.
And the exercise and movement helps relieve anxiety, and anxiety is what drives a lot of people to overeat. It's so cyclical. You mentioned the pain that people may feel, or the different types of chest pain, like upon exertion. What about in the middle of the night? Because that is, I'm thinking of another good friend of us who, in his late 40s, had a similar situation as my dad, but he actually was having a heart attack.
Yeah.
And but how do you know, like, how can someone maybe in the middle of the night, if they wake up, oh, is this just anxiety?
Yeah, so that's a problem is that certainly chest pain that is especially burning pressure squeezing in the middle of the chest that occurs during the middle of the night can be from heart disease. Very often it's not, and very often it's because they were having spasm of the esophagus, they were having a bad dream, they even having musculoskeletal pain, they're having acid reflux, and so I think you really have to, so it would certainly not be common for someone having bad chest pain during the night and then being able to go out and run 3 miles and not have chest pain.
Okay.
Because that wouldn't be common. It's
Okay.
not impossible, but so again, many people. So if a 15-year-old girl or 15-year-old guy says they woke up during the night having chest pain, the odds are it's not going to prove to be heart. And a 40-year-old woman who has no risk factors, the odds are the chest pain in the middle of the night is going to probably prove you may not be able to blow it off because there are some 40-year-old women that will have blocked arteries, but it's probably not going to prove to be the heart. 60-year-old man or woman who's got bad risk factors, their chest pain in the middle of the night could still be from non-heart, but it got a much higher odds of being from the heart.
And then when they're experiencing that at night and it is heart related, it's going to be unusual for it to be only at night at rest and not also happen with exertion.
Correct, but it's still if they have a bunch of risk factors, I think most clinicians would at least do a stress test.
Mhm.
In that regard.
Is there some, like, I guess, for people who do wonder, when do I like press the panic button, for, lack of a better phrase, like when do they press the panic button and that feel, or cuz I do think that that's something that so many people, they don't want to be a problem, they don't want to be a burden, they don't want to just be overreacting.
Yeah, so I think certainly the problem is it's pretty hard to ignore long lasting chest pain. If chest pain is continuing, then you probably need medical attention. And so
Past
even a 25 and 30-year
okay,
old, if they continue to have 30 minutes of chest pain,
gotcha.
they probably need to go in, even if it's ends up proving not to be the heart, and that's even more so for people who are in the age groups or who have risk factors that make them likely to
Right,
have heart disease. That's more percentage wise more likely that pain could be cardiac, and so it's pretty hard. I don't think people that need to go run in immediately for 30 seconds of chest pain,
right,
but if somebody's having 20, 30 minutes of chest pain, they probably do need to be checked, and not a month later,
right.
probably that day.
Right. I think that that's just, even knowing that statement is good for people to know that, and whether it's someone's spouses or friends, or just to kind of have that rule of thumb, because I do think that can be just a really hard line of, when do I say I think this is serious?
Yeah, and again, you gotta realize that most chest pain that goes to the urgent care and emergency rooms or into people's clinic is ends up not
Right.
being heart attacks.
Right.
The problem is that heart attacks are so serious that you can't, even if you end up seeing a number of people with pain not from the heart, um, you need to do that so that you don't miss the ones that are really the real thing.
So that you're erring on the side of caution. Right, right. Well, I appreciate your time on this. I think the takeaway from me, and sort of or from my dad and what I saw with that, is listening to our bodies, not fearing being a hassle to someone. If there's something that's either, like you said, there's pain, and if especially if it continues, or there's something that's new that you've never experienced this, and it's something that feels significant like that, at least, reach out to your healthcare provider, to your physician, to your primary care physician. At least stay in contact and communication, and ask that guidance. And then, like Dr. Lavie said, that feeling of like, when do we really worry if something is happening and it is that middle of the night and it's lasting for that extended time, then don't be afraid.
I think that's a
Yeah.
good way to put it. And and again, if generally if the pain is resolved and it never ever comes back, you probably don't need to overreact
Right.
about resolved chest pain. But even if it's resolved and then becomes recurrent,
Right.
you probably still need to
Right.
get checked out. So,
Yeah, there's a lot there, and there's a lot that's just unanswered kind of questions for some of us. And I like what you said of, because my first thought is like, everyone needs to go get a stress test
yeah.
right now. But I do understand your, kind of the logic behind that. So I think all of it comes back to paying attention and staying in close contact with your healthcare providers, and having that team that you trust and you can have open communication with.
Agree.
Awesome. Well,
All right,
thank you
Molly.
so
Thanks for
much.
having me.
Every time I have a conversation with Dr. Levy, I feel like I could like with him and listen to him for hours. There's so much to learn. He's got, just so much knowledge of the science, so many just decades of experience, hands-on patient experience. I mean, his focus is this world that we're talking about. He lives this, he breathes this every day. So I'm grateful for his perspective. Also, guiding us through when to be concerned, when to raise the question, and when to reach out for help, and also when to say things are probably okay. And also to maybe talk me down off the ledge of thinking that all of us need a stress test immediately. I do understand his perspective on that. I understand it makes sense. And really, again, as we said, it comes down to taking note, taking stock of our overall wellness, not dismissing warning signs, not dismissing behaviors, lifestyle habits that we may have had for decades, especially even if we've made positive changes in recent years. If we had a otherwise lifetime of certain habits or certain choices, being really honest with ourselves about this, about what our risk factors are, and taking this to heart for ourselves, for our spouses, for our partners, for our friends, our family, our grandparents, and recognizing that we can be proactive in our health. Not everyone is, and so people who we really love and care about, keeping our eye out for them too, and helping to gently encourage them when needed. So, truly grateful to Dr. Lavie for joining me to share his insight in this and let us know what you think. If this has resonated with you, of course, we always want to hear about it. I am registered dietitian Molly Kimball. You've been listening to Fueled Wellness and Nutrition, the podcast. And if you'd like more Fueled Wellness and Nutrition, please head over to mollykimball.com and you can follow me, Molly Kimball RD, on Instagram, Facebook, and Twitter. And if you haven't yet, please go to Apple Podcasts and subscribe, rate, and review this podcast. And join us next week for another dose of Fueled Wellness and Nutrition. Thanks for listening, and stay focused on living your strongest, healthiest life.